So I'm going to talk about what everybody has been exposed over we're past a year now in that pandemic, yeah. And so we started working on that last summer, basically at the beginning of the summer. So what I'm going to present are some results that were funded by the National Science Foundation. We got a rapid grant. None of us, so it's a work that has, so we're 3 co-PI, a colleague from the Math department, Yuri Milaiko, Alice Koenig, she's from the Computer Science, Data Science Institute here at the University of Hawaii as well. And then a lot of students, 2 of them are here. We have, since we started, we've had 5 graduate students working with us and about 6 undergrads. So it's really sort of a common effort. What is important is that none of us has had no clues whatsoever about epidemiology when we started, right? So we came completely new in the field, but I think that was the case of actually a lot of people when it started evolving in a pandemic. So we created that applied and computational epidemiological study group in the Math department, and as we started working on that. All right. So here just some basic data of what happened and how it started. As I said, it's been more than a year. So it was in January 30, 2020, it was declared a global health emergency, and the name COVID-19 that I'm going to use was officially accepted in February 11. So for the US, I followed a little bit Australia and New Zealand, more so New Zealand, because we felt there was a lot of similarity with Hawaii and mostly our island, Honolulu Island, and the number of, like the travel, the tourism, the size, but New Zealand really shut down to any external input. So then we started to differ a little bit. So the United States, the first case was February 29, and March 26, they were leading the world in confirmed cases. In Hawaii, the first case was March 6. That's when it was the first detected case. So it's I feel every mathematician is now sort of epidemiologic modeling. I have so many colleagues, and there are so many papers coming out about people doing that epidemiology, and it's been great. There've been a lot of also non-mathematician looking at the data, crumbling the numbers, and however, there was also, that came with confusion a little bit about what modeling means and what it can do. So I'm going to try to talk a little bit about that, about the modeling and also the different types of model. So I'll go a little further. So epidemic forecasting, it is still considered even by experts in epidemiological modeling that it is in its infancy. It's a growing field that has a great potential. A lot of progress have been made the past year due to the pandemic and due to the fact that suddenly everybody was sort of looking at the techniques that were used at the model. And but there is still a lot of challenges, and some of the challenges are going to be really hard to overcome because it's not just about having a better model. It's about having the proper data, and it is about modeling something that is much more difficult than modeling physical forces, right? We're modeling human behavior here, and therefore it comes with a big can of worm. So their models are very useful. They've been very important in that pandemic for making decision, even though I feel now as I look back, it was a lot of reactive diffusion to the numbers. Modeling, one of the issues that we had with the modeling is by the time data comes available, you have to understand what type of data exactly they're giving you. There is a lag. So with the modeling, we were always like 3 to 4 weeks behind when we could started to do any sort of forecasting. So we had to understand really what to do during an epidemic with the modeling. There'll be a lot that we can do after to understand better. But during the emergency, that was a little delicate. All right, so let's move forward a little bit in epidemic forecasting. So there is a really nice paper here by Moran and all that compares weather forecasting and epidemic forecasting. Weather forecasting is known to be very difficult. We've got much better. However, it's really hard to predict the weather within the next 5 days. Within the next 5 days is okay, but further than that. However, it seems that it's much more advanced than epidemiological modeling at this stage. That's the case that this paper made. And it was a paper that was published in 2016, right? So it was not generated just by the pandemic. That was something that was already discussed before. So disease models, there are a lot of different models. There are mostly two big classes of model, which are compartmental model and then agent-based model. And it's mostly the discussion that we're going to have today to try to understand them. The major issue in modeling is the fact that the data, they're limited, they come late, you don't have access. We really struggled having access to some data that we really needed, like contact tracing, testing, like who are you testing? Are you testing only once a person, or are you testing how often and where? What is the zip code of the person that has been tested, or contact tracing? How many contact tracers? We had a huge issue here in Hawaii, and there was a lot of controversy about that. So epidemiological models, so what can they do? And that was really important to understand. There was a lot of confusion from people. I spent a lot of the year in meetings with biologists, with the epidemiologists, with the decision maker from the state, and it was very confusing for them to understand about what is a model. If we were just making some I don't know, some very basic relation, if we have that percent of people vaccinated today and we keep the same rate of vaccination, this is how many people we'll have in a week. And a lot of people understood this as being modeling. And so that was a little, so we had to come and explain that modeling is not just making a rule of three and what exactly it is. So during the pandemic, the modeling, doing any forecasting was extremely dangerous because the condition could change very quickly. Mitigation measure would happen very quickly. You would have a lockdown, bar would close, restaurant would close, then they close the school, and then they start reopening that, and then travelers. So any forecasting was very difficult, and also the data that we had were very incomplete, even though we had that Mount Everest of data. Like, I don't think there were ever as many data as we had. However, it was very, very difficult to navigate. So the model, they're very good at understanding the past. They're very good at creating what-if scenario. So like, for instance, discuss some impact of non-pharmaceutical intervention. You're not forecasting quantitatively, but you're forecasting qualitatively. And I think that we've done a lot of that. And the decision maker were actually listening. And I'll give some example. And then the models are very good also at understanding what is important, what are the variables that we need to really understand and measure versus the other one that we might neglect and make the model a little easier. Or, for instance, one question when they started vaccinating, which is, by the way, the first pandemic ever where the vaccine was available during the pandemic. So who do you vaccinate? What is the best strategy with the vaccine? That was a very, very big question. And I'll show some animations that we've done on that. And then what they cannot do a lot. There is a lot that the modeling cannot do. Like, they were very often, they were asking questions and you would give a graph and it was like 100 daily cases in 2 weeks, and they would get stuck at that number. Even though you try to explain that number, you like look at the qualitative evolution of the curve, the number was really what they would get stuck. And we could not predict the accurate numbers because we cannot predict human behavior. All right, so the poster child, what was extremely successful is flattening the curve. Everybody, whether you're a mathematician or anything, everybody has heard about flattening the curve. So here I have side to side, and the or not number was also something that became very accessible, and everybody was throwing up, was throwing the sentence flattening the curve and are the reproductive number or not. Not always really understanding what it means, the or not, but the fact was that it became very popular. And here you can see side by side, the red and the orange is about the pandemic, flattening the curve with intervention. And the one on the right is about climate change, which is another huge question that we have right now. And you can see that human intervention are also, the goal of the human intervention is also to flatten the curve, right? So it's not a concept that is unique to epidemiological modeling, because I've made that relation with the weather forecasting and global temperature. You also try to flatten that maybe over a longer period, but less of a magnitude. So why is it so limited? Why, given that all the effort that we've done and the amount of people that were working in that, the only really two poster child were flattening the curve, and to some degree or not. Okay, so here is a little blurb. I don't want to spend too much time on that, but there are major difference between the weather and epidemic modeling that comes from the paper that I listed before. But if you do robotics or if you work with machine, you can also make that correlation. Epidemiological modeling is mostly about human behavior. And that is, people are very, very, very complex, and modeling people's behavior is impossible. You don't know if tomorrow you'll have, there've been super spreader events that were due, like for instance, in some specific setting, people would decide not to wear a mask, and therefore this is something that you cannot predict in your model, that a decision like that will come into an evening, or there were other decisions like this that are not predictable, that cannot go into the modeling. Then the transmission in epidemic, yeah, that's exactly what is said here. It is governed by human social behavior. So human are driving the pandemic, versus like if you send, that's a little, when you think we have a rover on Mars, on another planet right now, that is responding very well, on which we have a drone that is flying and bringing images. However, we cannot give you the daily count of the numbers in Sydney the next day in terms of the new diagnostic cases for the COVID-19 or that kind of thing. So it is really how different like modeling with forces versus modeling with human behavior. So here are the two basic models. So you have differential equation based, so those compartmental model, and then agent based. Okay, and you typically people use one or the other one. It depends where you raised using ordinary differential equation, or like we're going to go through a discrete version, but or you raise more into networks, and therefore you'll go into agent based. But it seems that there is no such a thing, I believe, as a better model, right? It depends. Some model do well something, some model do well different things. So using them together, or even creating a hybrid model, is probably the future of epidemic modeling. So we took the Honolulu County, that's the biggest island, that's Oahu Island in Hawaii, and I'm going to show the graph, and I'm going to show some of the modeling and compare between those two models. But first I'll go a little bit into the model. So you have the equation-based model. So that's the SEER model that now every math department and beyond teaches in their modeling classes, the SEER model. And the idea is really that you aggregate the population into compartment. So you don't have, people are anonymous, right? It is really computing density of people, the evolution of density of people, rather than at the granular level that the agent-based model have, where you really go and look at the evolution of each individual. So typically the SEER model, you have the susceptible, people that are not sick, but that could get sick. Then you have E, the exposed. Those for us here, we're going to look at them as the asymptomatic. And then you have I, the symptomatic people, and R, the recovered. Okay, and then you have a lot of variation over those models. So I'm going to go over one of the variation that we've done. So G's here is the generalized one, and that was based on some work that were done during the SARS 2003 epidemic. Afterwards, a group went. And so here, what was important in COVID, and it still is the fact that we have the asymptomatic individual that are infected but not displaying symptoms, that do carry the infection. They might never display symptoms, and they might transmit the disease. And that was one of the major issues that took us from SARS 2003 to a complete global pandemic, because asymptomatic people were actually transmitting and spreading the disease without knowing it. So you can be asymptomatic for 14 days. So if you look at this, you don't have a line that goes from E to R. And this is one of the modifications that we have made. You can be asymptomatic throughout the entire course of the disease, of the illness for you, and get into the recovered. So that's something that was introduced. And every compartment, E and I, were broken down into subcategory, into subcompartment, in order to reflect the stages of the illness for the patient. So it means that you're symptomatic, you have the disease, and you're showing symptoms. So the first 2 days you evolve, and then you have stages, stage 3, 4, and 5, and you might stay in stage 3 for a while and then go be recovered because you don't get very severely ill, or you can move and eventually go to the hospital, etc. So that was one of the change that we've made. And this is Pratik that is here. He has made the diagram to illustrate exactly all the compartment, all the bucket, and how they play with each other in our model. So the PI and the QI, you can think of them as probability, right? The PI will be the probability that if you're asymptomatic, it's your probability to actually develop symptoms. And you have different PI because it depends the stage at which you are as an asymptomatic. And then the QI is about isolation, getting isolated. So that can be, isolation means either you start developing symptoms, they get severe enough so that you get into the hospital, or then they started doing contact tracing and testing, not at the beginning, but down the line. And that's also one way where you can get isolated. If you're tested positive and you're asked to go and go into quarantine, then you would get isolated. So those PI and QI basically represent those probability to move on with the symptoms or to get isolated. And if you look at the system, so you can write it as a differential equation, or here you have just the discrete version. This is what happened. And the very important parameter that is governing the spread of the disease is really that lambda t. That's known as the hazard rate. And here, also one thing that we've done, we separated individuals into two groups. So we had community and then healthcare workers, right? Because they did not interact the same way. They had more masks. However, they were more exposed to people with COVID. So we treated the healthcare worker and the community in a different way, like in terms of the parameter and in the terms of how they are exposed to the disease and how they can spread the disease. So this basically, that hazard rate, where the beta here is the transmission rate. So that's related to that R0 number, so our RT number, because it changes. The R0 is in the ideal condition when you don't have mitigation measure, where you have uniform population, etc. But then you have the RT that takes into account all those things. And then we introduced also contact tracing into the equation. So here you can see the lambda C is the factor that govern the spread of the disease among susceptible in the community. So it can be transmitted by people in the community. It can be also transmitted by people in the healthcare system, but the row that you have here is less than 1 because the healthcare were careful not to mix with the community, or they were usually more aware of the consequences of reckless behavior once it started. So then here, that's the lambda, the hazard rate for the healthcare workers. So then, and this is a picture that we've done, and it is the optimized fit for Honolulu County. Okay, so this was, so you can say, like, so what do we see? The red little dots, those are the actual daily cases, the new daily cases that were provided by the Department of Health. Okay, so you can see some, they go up and down. There is the issue, like those are the raw numbers. It's not the 7-day average or anything. It's just the raw numbers. Like on Monday, typically the number were smaller because a lot of the testing was not processed over the weekend. So there is a lot of things like that. But the blue is our fit. It's our model, and you can see the beta here. We changed a lot of time the beta throughout the evolution. We didn't just change them artificially whenever we felt. Okay, the beta here are changed. Those are measures that happen, and you can see that was a nightmare actually, because nobody knew exactly what were the rules. They would close the park, then they would close the beach. Then you can walk on the beach to go to the ocean, but you cannot stay on the beach, and then you cannot hike, then you can hike, but you cannot go to the restaurant, they were closed, then the school closed, then it was like, it was very confusing, and there was a lot of changes, a lot of mitigation measure. However, because there were a lot of them, we had a lot of parameters we can play with and fit well the data. So that was really not bad, and as you can see, the model fits the data very well. But again, it was due to the fact that there were a lot of mitigation measure, and you do not stay with the same beta for a very long period of time, because this is an exponential, it's an exponential growth or exponential decay. So with time, if you keep the same beta for a long time, then the error gets very big very quickly. Okay. So that was from March 6 to October 15. I'm isolating that period because that's the period where basically we had no travelers. If you were to travel to Hawaii, you could, but you had to go for 2 weeks in quarantine. So people did not. We had basically 300 people coming to the island per day versus 30,000 on a regular year. So it really killed travel completely. So we completely neglect the travel for that period of time. Okay, so those were, so I'm going just to show you, I'll go and I'll share another, let's see, oops, sorry. Let me bring back. Okay, I wanted to show you a little bit the dashboard, and where is that dashboard? I lost it. Is it here? Yeah, sorry, I'm coming back. I'll be sharing soon. Okay, so that guy is coming here. So up. All right, so let me share the dashboard that we had. It was like, right now, it's spectacular what they've done. But that's a long process. That's not what we had at the beginning when it started. But I have to say, Hawaii is the state that did the best in the US, okay? And you'll see after October 15, we basically controlled the curve. There was no more spike, despite the fact that travelers were coming back, despite the fact that we had the holiday, despite the fact that we were that we've been reopening, but we've done spectacular. And I think one of the reasons is that it was like we kept informing the population. The dashboard was always updated. People knew exactly what were the numbers. And then there was a lot of feedback control actually from people behavior to adjust. So this is where we got our data from the Hawaii dashboard. And we would get the daily numbers. So the little orange dot that you see, that you saw before, test positivity rate and ta-da-da. But again, at the beginning, it was not as, we didn't have as much information as we have here. Now we have a lot of information about the vaccine, and I'll come back to that after, okay? So then I wanted to show some of the things that we have done. Also, we've done a lot of animation that were shared with the public. Some went onto the TV station, and I'll share one right now, a little animation, and that was made about contact tracing, because the numbers in July, our numbers were going up, and there was a lot of confusion about the level of contact tracing that were made. So we did an animation that was to explain to people that the state had to step up by doing contact tracing and testing, and that the individuals also had to step up by being compliant with the rules, which was wearing a mask, etc. So I'll just play a little bit of the animation so that you can see what went out to the people.
This is the forecasting for daily cases. The red curve shows aggressive contact tracing and low compliance from the people. The blue curve, top one, is after good compliance and mild contact tracing. The orange curve is after good contact tracing and good compliance.
So really the message here was like, if the state get their act together and do fantastic contact tracing, that's not enough if there is no good compliance. If there is low contact tracing or mild and good compliance, that's not enough. We needed both in order to be able to control the curve.
This is the forecasting of ICU
really
events, and it's pretty similar to the previous one. Notice, this bottom dashed line here never goes back up because it is controlled. And if we want to be able to surf that wave safely, as our surfer friend just did, we have to be responsible. If we are not compliant enough, and if we only count on the government, we will go on that plane wave and crash, like our surfer friend just did. Let us all try to keep the wave down so our surfer friend can surf safely. So please stay at home as much as you can. If you have to go out, wear a mask.
So that's some of the, like, I'll show another one that we did after. For vaccines, but this is one of the animation that went out and that was shared with the public. And we also, so the animation that you see are done with our modeling, right? This was really based on the number from the DOH dashboard and then forecasting using our model. And then we really tried to hammer the state by saying, you cannot kill the disease, right? You cannot expect to be at zero, have zero numbers. What you have to do is control the curve. It's too hard to crush it. So that was really the message, because the state started suffering very much. A lot of people, unemployment, while we were doing the best, we had the highest unemployment in the US, because we survive on the tourism, and we needed to be able to open it. So we needed to be able to find a way to control the curve and not see that the only outcome was to bring it to zero. So then we started incorporating travelers. So with the travelers came a big can of worm, and this is a diagram again that Pratik has made. So we started having a large infusion of travelers, but we had a safe travel program. So we had to find a way to incorporate that in the model, which means like who is tested. The rules were like, you can come. If you're untested, you have to quarantine for 2 weeks. If you're tested, then you can skip the quarantine. But there we had to take into account the fact that you have false negative. So you might test negative. We had them, we followed that. So all of these had to be incorporated into the model, which made it a little more intricate and started showing that a compartmental model will be very hard to handle down the line as we were adding that type of behavior. Then we had parameters that we had to use. And this is the curve that came afterwards. So you can see here like October 15, that's when the safe travel program started. And then you can see we actually controlled pretty well. We had sort of an uprise because we had more people. Suddenly we went from 300 to 3,000 to now basically back to normal, to 30,000 people coming every day. And again, you'll see the curve has not, we had no spike since we started introducing the travelers. So another thing, another animation that, another little piece of animation that I wanted to show you as well is here that we've done. That was, let's see. Okay, that was this one for Thanksgiving.
Main islands of the Hawaii archipelago are all now facing COVID-19. Pandemics are extremely difficult to understand, to model. It should be easy to predict daily numbers. Indeed, modeling is very advanced, as illustrated on October 20, when it helped NASA's OSIRIS asteroid to collect dust. But it is not. The spread of viruses is people-driven, and people are very, very complex. Here is a snapshot at daily cases represented per zip.
So here, that sounds like simple, right? You have daily cases per zip code and you do a time series. That we're the only one that were actually able to do that, because the data, they would not release the data because confidentiality, that was extremely difficult. So it was like near impossible to know where the disease was, right? So you knew the count for the Honolulu County, but you had no mean of being able to understand where they are. And once we started looking at it and have some information, we could like see some of the neighborhood that were very affected. For instance, one of the major issues is that the Pacific Islander population was very affected. They're only 4% of the population, but they would make up 30% of the daily cases. And then as we were looking at this, we would see that their neighbor, like it would come obvious on that type of data. So, but that was difficult.
Canada celebrates Thanksgiving mass compliance, but at higher numbers.
And so then what we did to the public.
Thanksgiving is a time of travel. This might result in more cases from the mainland introduced into our islands. If we were to assume that since Hawaii started the pre-travel program, we would have 50% more travelers at higher numbers now for daily cases.
So again, this was done with our modeling and with the real data. And it went to the public. That was the one that went into the news. That was before Thanksgiving because everybody was very nervous. Canada saw a big spike after their Thanksgiving that is a little ahead of the US. So we were really trying to be proactive rather than just react to the number. All right, oops. Let me go back to the presentation. That is here. So, and then the vaccine, okay? So December 2020, the world started vaccinating, and then that changed the entire game of the spread, right? Because now it was a competition. Before it was like us versus the disease and having our behavior, but now there was a competition between the virus and the vaccine. And in particular, the main competition that we are still actually facing, because there are places where the vaccine, where most of the country is not vaccinated, like in India, they have that huge spike, and this is where some mutation can come up and then challenge the vaccine that we have received. So it's really a competition, and we have to vaccinate as quickly as possible, not just to prevent people to get the current COVID-19, but to prevent the mutation. So here again, Hawaii has done really well. 53% of the population is currently fully vaccinated and 60% with at least one shot. And that means that we're going to reopen now, and we're going to install a vaccine travel safe program. Now it's between the island. We can travel like the local, that will be for local residents. We can now travel in and out without having to use a vaccine between the island, and they're going to extend that to the mainland. So as an island resident, if you've been vaccinated and you have your vaccine information, you can skip the testing in order to come back here. And then one of the major issue is really mutation. Are we going to be able to vaccinate the world fast enough in order to prevent a mutation for which the current vaccine is not going to be as efficient? So then we're still with the SEER model. And then what do? You want highlight people that have been vaccinated, but because the SEER model is aggregated people and density of population, you cannot decide who is vaccinated or not. So you have to do a new compartment. And then, so this is sort of, this slide shows like how you have to introduce new compartment, and I'm going to show you the diagram. And this is just with one vaccine that required 2 doses. So you can see you have to duplicate the initial vaccine. You have to duplicate the initial diagram because the vaccinated people can still get exposed to some degree, lower of course, but they can still get the disease and they can still interact with the community. So it becomes out of hand very quickly. If now we want to introduce mutation into the compartmental model and decide which person get which strain of the COVID-19, you have to add compartment of all of those, and then you have to understand how every bucket works with every other bucket, and it becomes really very quickly out of hand. But for the vaccine, this is how the equations are modified. You have in the pool of susceptible, every day you take a bucket out, that is the people that were vaccinated, that were vaccinated 2 weeks prior, or like that are 2 weeks after the second dose, etc. And then you have an interaction between those, and you have their evolution based on some rules. So then the hazard rate have to be modified as well. And again, it is all doable. We have done it. Now the Department of Health, the dashboard. So maybe I don't need to show that, but they're very good. They gave us information about like a time series every day, like how many people received their first shot, how many people received their second shot. They eventually gave us the demographic, etc., and we are able to introduce that into the model. Well, the demographic for the compartmental model is very difficult, but it will go into the agent-based that I'm going to go right after that. But this is the entire course and the model fit from March 6th, from the first case that we had, through April 25. And if we were to keep here, the curve is down. So we have very few cases. We are about 30 cases. So again, we had one major spike in October followed by a lockdown. Then we had a sort of a steady increase due to the travelers. And then because the vaccine it went down, but then it went a little bit up because we started reopening. But again, as we were reopening, very aggressive with vaccination, and eventually the vaccine is damping completely, even the new mutation, because now the strain that is dominant in Hawaii is the actual California strain that created a huge spike back there in the fall and winter of 2020. So now if I go to the agent-based model, so it's much simpler, right? So compartment, differential equation, now age-based model. So that means you basically have a network where every node is an agent. So every node is an individual. Okay, so they really capture the behavior of a single individual, and you can add to that individual, let me go there and show that picture. So you have a state. Every agent has its own state, like age, whether the person is infected, whether the person is diagnosed, the date of infection, etc. You can really associate that individually to every agent. So very different from compartment. However, now and then you have to build the network. Individual, you're not in contact with everybody on Honolulu, right? So you're in contact with a subpopulation, and you have different type of contact. Like here, Mostly in the model that we're using, you have contact that are community, that are at home, at school, or at work. Okay, if you work, you don't have contact at school, but there are some of our students do work, so they might have all of them. Okay, but then, so you have those agents and you have that network. And the network, as you increase the number of the population, the network becomes very heavy, and it's computationally. The issue with the agent-based model is computational. Okay, so as it was written here, the use of them, and not just for epidemiology, for a lot of different purpose, exploded in the 90s when the computational power really increased and became very available. But still now, if we are to do a model for the entire US with a lot of connection, etc., and a lot of granularity, that's computationally very, very, very demanding. So basically, you have a set of agent A, which for us is the set of people within the community, like the people living on Oahu, and then you have the state. Okay, it's some that every state of an agent belong in S. So for us, it's some data about the age, etc., some real numbers, and then some binary numbers. Are you vaccinated? Yes or no? Are you affected, infected? Yes or no, etc. Okay, and then you can keep adding them, and the evolution is just a map. You keep iterating on the state for every individual. So this is where, like, so again, this is the contact network that you have. And then you can introduce vaccine. That's now very easy. It's just one number that you add to the state of every individual. You do not change the network. You do not add compartment. You just change the state. You have just one more variable into the state. So that's conceptually very easy. That becomes like, again, computationally, it's a different picture, but conceptually, it's very easy to modify an agent-based model. So the one that we use is known as COVASIM, that was developed by the Institute of Disease Modeling, that's funded by the Gates Foundation. And it's an open source, and we started working with that one. And here a little bit of information. It has, every agent has 39 variables that are available and that you can assign. It's a stochastic agent-based model. The SEER model that we use, the discrete was deterministic. This is stochastic. So when you create an output, you do that as an average over multiple simulation, typically 15 to 20, that you can parallelize to gain time. And so it has its own demographic data set, but we got a more refined synthetic population here for Hawaii that we used for our simulation. So what does it do? Well, it simulates the state of individual people, okay, over a number of discrete time steps. So for instance, then you can look at how the evolution of given demographic, which we cannot with the compartmental model. I don't know how the 19 to 25 evolved, whether the one that were driving the disease, I don't know, but the agent-based model can do that for you. Now, the limitation that it has, it's not user-friendly for that one, at least the COVASIM. You have to be able to code and be very proficient in Python. Data fitting is difficult. So what we used, we started with the SEER, the compartmental model. We were able to do some optimization to find the beta, the optimized transmission rate, and we used that as an initialization for the agent-based model. It's computationally very expensive, and it was not well suited to introduce travel. Like, for instance, travel, the COVASIM, it has a constant population. You cannot change the number of agents. So that made it impossible to incorporate travelers. And therefore, we had to do that in a different way. And what we did is that we actually changed the network, or we changed some probability for the people that work in the travel industry, because what we noticed is that travelers, like tourists, were not really the issue. The issue was the resident coming back with the disease, and then it would seed into our community. That was community spread. Or then the people here that were working with the tourists, then they would get it, and then it would go into community spread. So we introduced travelers in a slightly different way. But this is a diagram. So you have an initialization to do, and then simulation run and you just iterate over that. Okay, so that's what the CovaSim simulation. So just some basic data that I might skip because it's already 150. So I can show you a few more graph. And this is a comparison of the two models. So you can see they match really well. Okay, but at the very beginning, using the agent-based model was extremely difficult. So the compartmental model was very good at the beginning to give us the tool to do the fit. And then with the vaccine, we shifted, because they were easier to incorporate, we shifted more to the agent-based model. So we did a vaccine animation, and maybe I can show that one, because that one was important. And the reason it was important is that there was a lot of discussion about vaccination, and the discussion were mostly the UK were starting, they were having at the end of last year a huge surge in their cases, and they were debating, should we vaccinate as many people as we can, even just with one dose, or should we stick to vaccinate less people, but with 2 doses? So the UK said, we're going to vaccinate as many people as we can with 1 dose in priority before finishing the 2nd dose for the people that got the 1 dose already. And then people were wondering, should we do the same here in Hawaii? So
many countries, including the UK,
we created those animation to show that it was actually not the best strategy. And for us, sticking to 2 doses per individual was best. And that's what we did.
However, might not be effective to reduce COVID cases in the state of Hawaii. Here are some simulations with different scenarios in Honolulu County.
So those simulations are done with the agent-based model, and we were just forecasting what would happen if we had different level of vaccine and different strategy for vaccination.
Red line here assumes vaccination of slightly under 350,000 individuals in phase 1A, 1B, and 1C with 1 dose of vaccine. The green line assumes a 50% level of vaccination compared to 1 dose, but with each individual receiving 2 doses. And the orange line assumes the same level of vaccination than for 2 doses, but assuming only 1 dose was administered. As we can see, the gain produced by vaccinating twice as many individuals with only 1 dose would not flatten the curve significantly. So due to uncertainties related to the 1 dose efficacy and length of protection, these simulations.
So the takeout here was that we could vaccinate everybody with 1 vaccine. That would be slightly better with only 1 vaccine, but it came with the fact that we didn't know how long it would last, and the people were not as well vaccinated as with 2 doses. So because the number were low and we were controlling the spread, it didn't seem like the unknown were too big in order to take that risk for very little gain. So the state decided to keep vaccinated, but to keep prioritizing the 2nd dose.
Suggests that at this time, distributing for the state of Hawaii. Multiple new strains of the virus that causes COVID-19 have been documented around the world, and some.
So then there were a few other animation that we've done about the strains. So the B117 is the one that we had in Hawaii, that we have, and that is actually the largest of the variant that we have. And so the question was, what level of vaccination do we need to make sure that a new strain is not going to take over and give a rise? So that's basically what we computed and what the simulation here say. So we did some scenario as well.
More transmissible.
And so the outcome, the takeout of our simulation and advice was really the level of vaccination that we needed and make sure that we might have a slight bump, but that it would stay controlled, and then it would, again, the vaccine would flatten the new strain. So that was another animation that we shared. And that's exactly what the state has done. They privileged, and they really were very aggressive in terms of their vaccination campaign. And it worked really beautifully. So here are some, like if I summarize a little bit, so conceptual complexity and data fitting. So conceptual complexity is much bigger with the compartment model, and it gets out of control very quickly to make sure that you have every bucket related to the bucket that they should be related, and have everything of all of this into account. Data fitting, I mentioned that before, better with the compartmental model and using that as an initial condition for the agent-based model. Now, computational complexity, of course, much higher with the agent-based model. And here is a simulation that we've done over 150 days. And so everyone is an average of 15 simulation for every scenario. And just increasing the population shows that you increase the computational time. Those are second, and this is the number of people. And now the student is working on the entire US population, and that will take a few hours in order to compute. I forgot, he came with 8 hours, I think, or something. So just to finish, I wanted to come back to the Hawaiian archipelago again, because the New Zealand and Australia are also an island. And with the fact that at the beginning, the state was imposing intervention measure the same on every island. And it became clear that it was a wrong strategy, that every island were their own ecosystem for the spread of the disease, even though we're 30 minutes fly away. And the reason, one of the important reasons, is that the demographic is different on different islands. The ethnicity is different on different islands, so human behavior. And when we started reopening to tourists, the density, the ratio of tourists versus population is different on different islands. So at the beginning, every decision was made based on Oahu, because that where the numbers were driving, that where we had the largest number. But then when we started to reopen to tourists, they tried to impose to every island for the same safe travel program, and Kauai really fought the state in order to not allow for the same rules. So they didn't have any safe travel because their numbers went they went up very, very quickly. Their population was much more vulnerable to tourism. And then Maui, you can see the blue one here, the curve. Maui got out of control, and therefore they had to come and really understand and put a microscope on what was going on Maui, and have rules over there. And it was mostly super spreader event, actually, but Maui has a very large tourist population versus the resident. And here just the little game that we did at the end, in order it was to measure different curves. Like if I can show you, this is, so on the left you have Oahu Island, the second one is Maui, that's the last slide. And then the last one is Hawaii Island, the one from the volcano. And on the right you have Iceland, we compare to other islands. So you have Iceland, you have Japan, and you have Puerto Rico. So it shows also that there is heterogeneity in terms of how the island responded to the actual pandemic. And in order to measure, you might think, okay, I'm going to measure the difference between the two curves by doing, I don't know, measuring the L2 norm. But then if you take one curve and you just shift it, because they started doing the measure a little away, it's the exact same qualitative curve, but shifted along the time axis. And then the L2 norm might be rather big. And that's not what you want. Even if it shifted along the x-axis, the two curves might still look the same. So we started incorporating the notion of merged tree that really, it measured the topology of the curve, if you want. It measured the topology of the peak and how small and big peak came one after the other, or if you had two peaks one after the other. And then we compared the complexity of those merged tree as a topological tool in order to decide similarity between the response and the evolution of them. All right, I think that's a lot, I'm sorry, but that pandemic was a lot. And there is a ton of stuff that has to be said about this pandemic here.